Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center. Today's medical tutorial is on Whipple procedure complications. The Whipple procedure is an operation that carries significant morbidity. Recent data has shown that up to 40% of patients have one complication or another, albeit minor. Today's video, however, is on the major complications from the Whipple procedure. The first complication is pancreatic fistula, or pancreatic leak, as we call it. As you recall from previous videos, the pancreas and the jejunum are anastomosed or reconnected in several different fashions. We tend to favor the ductum mucosa for ducts over 3 millimeters. This anastomosis is at risk for disruption or leakage. National statistics show that the leak rate is somewhere in the 10 to 12% range, or at least clinically significant leaks are in that range. Factors that cause this anastomosis to break down are not completely known. Clearly, studies have shown that ischemia to the gland may play a role. Whether the patient develops pancreatitis or inflammation of this pancreas after surgery, in that situation, the inflammation may have a role in the breakdown. Technique clearly is important, but despite perfect technique from high-volume surgeons, nobody is immune, or very few places have shown leak rates to be lower than this, 10 to 12%. So this is the more morbid or major complication, which we call pancreatic fistula. Pancreatic fistulas are divided now into A, B, and C based on the International Consensus Conference. It was hard to figure out a lot of the data because different institutions, when retrospectively or prospectively reviewing their data, were using non-standardized definitions. So recently, in the past few years, the International Consensus Conference has established a consensus of what the definition of a pancreatic fistula is. And because this video is not for surgeons but for patients, I'm not going to go into great detail, but an A fistula generally doesn't alter the course, the postoperative course. It may be that the effluent in the drain alone has a high amylase, but the patient has no fever and it has not interfered with feeding. Type B fistulas are a different story. The patient has signs of an infection, may need to be started on antibiotics. So usually delays the resumption of oral intake. There may be a prolonged ileus. There may be delayed gastric emptying, which we'll talk about later. And then there's C fistulas, which usually are more severe sepsis, requiring reoperation. Type B fistulas may require placement of additional drains percutaneously. So this has helped standardize what we call the definitions of pancreatic fistulas. Now, a lot of what determines whether a patient develops a pancreatic fistula, aside from technique, are the texture of the gland. So what we call the texture of the gland, and surgeons make a note of this during the procedure to determine whether the gland is indeed a soft gland or a firm gland. Soft glands have fistula rates which are significantly higher than firm glands. Firm glands are usually pancreatic ducts that have been obstructed from a cancer for quite some time. Soft glands are seen usually more with non-malignant tumors, such as serous microcystic adenomas or intrapapillary mucinous neoplasms, IPMNs. So texture is important. Soft glands can actually have fistula rates as high as 30% in some series. So along with pancreatic fistulas and determining whether they're in the category of an A, a B, or a C, are associated complications related to pancreatic fistulas, such as more commonly intra-abdominal collections or intra-abdominal abscesses, which could need further treatment and then delay recovery. The second more common complication from the Whipple procedure is called delayed gastric emptying. And this essentially means that the stomach does not empty as well as it did before surgery. It's not entirely clear as to why this happens. Some people say that there's a hormone called motilin, which is present in the duodenum, and part of the duodenum, or the full duodenum, is resected during a Whipple procedure. And then there's a decreased motilin. It could be related to the autonomic nervous system, or there could be factors that we really haven't identified yet. Almost everybody has some degree of delayed gastric emptying. The majority, however, can continue to eat without any difficulty. About 20% of patients will develop significant delayed gastric emptying, and maybe 10% will develop it. 5 to 10% will develop such a severe case of delayed gastric emptying that they actually require to go home on what we call total parenteral nutrition, or nutrition by vein, until the stomach recovers. The more severe cases usually recover within a 4 to 6 week period. The most severe case I've seen in my practice is closer to 3 months, although that is extremely rare. Many times patients have delayed gastric emptying, and and what turns out is that they have had an undiagnosed small pancreatic leak after the drains have come out, and that there may be an undrained collection under the stomach, which is basically exacerbating the delayed gastric emptying, or actually being the cause of it. So those are the main or the two complications related in particular to the surgery itself. Pancreatic fistulas or pancreatic leaks can also lead to GI hemorrhage, which sometimes is identified with blood in the drains. We've talked about the arterial anatomy before. There is an artery called the gastroduodenal artery. This is the common hepatic. This is the proper hepatic. And this is what we call the GDA, which we ligate during the resection part of this procedure. If a patient develops a pancreatic fistula, sometimes the drain is in this area, and this tie either comes off or erodes because of the infection from the pancreas, leaking here. And this can be a life-threatening complication, which can generally be dealt with not without having a reoperative surgery, but sometimes does require reoperative surgery to try to repair the bleeding. So this is a more devastating complication of a pancreatic fistula. Other complications related to abdominal surgery that aren't in particularly related to Whipple surgery do include deep venous thrombosis, wound infections, or basically infection of the incision, pneumonias, heart attacks. These are all not specific to the operation, but one must keep in mind that this is a significant and complex intra-abdominal procedure, so these complications are all possible. I thank you for listening to today's video.